This child is 5.5 years old, and he has a diagnosis of hemiplegia. He has impairment both on his upper extremity and lower extremity. I would say that his upper extremity is significantly more involved than his lower extremity. He started receiving regular therapy sometime when he was about 2 years old. He was a child who sat. He could get into sitting and out of sitting, but he really wasn't interested in movement. So our goals for him have been to really increase the active use of his right side. We've worked on trying to get him more in touch with his right leg in terms of being aware of where it is in space, increasing his sensory awareness of his leg and what position it's in, and in active movement. Improving his gait has also been a goal, increasing weight bearing on his affected side. And then in the upper extremity, to preserve his passive range of motion. He has a lot of edema in his hand. He has recently gone through restraint therapy to see if we could get more use out of his hand. He was in the 3-week program of being casted for 3 weeks and having 3 hours of therapy a day during that time. He did gain some function in his right hand, and he did definitely improve his sensory awareness of his right arm, but he really does not have significantly greater functional skills in that arm. He uses his elbow to help him hold things, and he will place his hand down to stabilize. In the past, only when reminded to do so. Now we are seeing more spontaneous placing of his hand for assist, but not a lot of change. Basically, he has some spasticity, some tightness in his heel cord, although he does have full passive range of motion, and he pronates his foot. We're looking to get a nice knee extension with hip flexion. If a child can fully extend their knee, then they get heel strike. The AFO itself holds his foot in that dorsiflex position. Although I stress to a child, get your heel down, that's because that is much more concrete and easy for them to understand than extend your knee. I use the words get your heel down or reach with your leg, but what I'm really focusing on is he getting full knee extension? He has always worn a number 2. Because he pronates his foot, he has no usable active dorsiflexion. He actually doesn't have any usable plantar flexion, and he is not able to elicit movement in his foot, essentially. When he moves his leg, you will see some active movement of his ankle, but he is not aware of that movement and is not in control of it. So I wanted to put him in an orthotic that would keep his foot in normal alignment, that will support his transverse arch, and that will prevent him from pronating and everting. And he's had orthotics since he was about a year old. I work with him in kneeling and half kneeling, and I'm looking for a nice awareness on his part of pressure on his foot, what it feels like to bear weight on his foot, not in a standing position. I do a lot of pelvic work to strengthen his pelvis, both in kneeling and half kneeling, and so I will do a lot of resistive work at his hips. And that resistive work has him strengthening. It's a straightforward strengthening activity. It's more challenging in half kneeling than it is in kneeling, and I do need him to try to isolate one side from the other, but also to be able to recruit as much as possible when we're wanting him to really stabilize at his pelvis. Functional neuromuscular electrical stimulation is a modality which can be used in a number of ways with children with motor disabilities. Research has shown that if using electrical stimulation, you have the off cycle of the stimulation to be at least equal, preferably greater than the on cycle, that you will not fatigue a muscle, but you will build strength in it. So the child can be not actively using a muscle, but with an electrical stimulator on it, it will build muscle fibers. To actually fatigue a muscle, we'll have the on cycle to be longer than the off cycle. We'll use this sometimes on spastic muscles, because for some kids it's not so much that a muscle doesn't have the strength and capability to move, but that the opposing muscle is so strong in its spastic pattern that it doesn't allow that muscle to work. I will use electrical stim on a child who has a lot of plantarflexion to fatigue that muscle some, and then I will be doing activities that require that anterior tibialis to be really firing and working. And one way to get the anterior tib to work is to have kids do unilateral standing. The higher level you put it on, definitely the more uncomfortable it is. And it's a very fine line between, I feel it, but it's okay, and then, I don't think I like that.
Don't do that. Don't. Don't do that.
I know it's difficult, huh?
Don't.
And that child doesn't have a normal sensory system, and so he was feeling something, but he couldn't pinpoint where it was, or he wasn't even sure how to interpret it. We also did stepping with what we call the stepping stones, which are the half balls. And that's looking for a little more preciseness in where he puts his foot and increased weight bearing, because when you step on something soft, you tend to push down harder on it.
Heel on the number. The heel on the number.
I can't do it. I can't do it.
Yeah, you can do it. I saw you do it the last time. There it was. Right on the number. Good. Right on the number. Right on the number.
I want him to see the difference of if you step hard on this, what sound it makes, how it compresses, as opposed to his uninvolved side, which compresses differently.